Dr. Thomas Simmer spent decades inside one of healthcare's most stubborn paradoxes, a system drowning in data yet starving for insight. As a physician executive and chief medical officer, he's operated at every level of that system, from the exam room to the boardroom. His answer to the tension between technology and clinical judgment wasn't to pick a side. It was to architect a model that refused to separate them. The result? Michigan's patient-centered medical homes, a framework that quietly redefined what personalized care could look like in an age of algorithms. But Dr. Simmer's story goes beyond blueprints and policy. We explore the friction at the heart of modern medicine, where wearable devices and AI-generated insights meet a physician's irreplaceable gut instinct, and why getting that balance wrong can cost more than just efficiency. He offers an unflinching look at what it takes to lead transformation inside a system that doesn't always want to change. From the exam room to the architecture of statewide reform, Dr. Simmer brings a perspective that's equal parts clinical and visionary. This is a conversation about what technology can do for healthcare and what it can never do without human beings being at its center. I've known Tom as a highly respected physician and a true legend in the healthcare transformation, but this conversation showed another side, a deeper look at the person behind the credentials. Tom is genuinely humble, endlessly curious, and passionate about mental health and physical health and the well-being of others in a way that never feels performative. He's also, without question, one of the kindest people I've had the privilege of talking with. I think you'll feel that coming through in every answer that he gives. Thank you, and I hope you enjoy our conversation. Okay, thank you, Dr. Simmer, for joining this podcast. We're going to go ahead and start with your years of leading healthcare transformation across Michigan. And what I wanted to kind of find out, was there a single moment, a patient story, a policy decision that made you think this is why it all matters? So is there anything that in your Rolodex, in your mind, that you can think of is that this was an example that I often go back to and think this is why it all mattered?
Well, I can sort of go back to the time when I changed courses in my career because of the ideas that were not really coming together. I had run the residency program at Henry Ford, and my focus was creating better healthcare for the future by training the physicians who would be delivering that care. And we focused on knowledge, attitudes, and skills. And so every month we evaluated people, and we worked hard to develop an educational process that would develop those skills. And at that time, Edward Deming was invited to come to the health system. He was more a process engineer who had made his fame in Japan post World War II, creating the auto companies there that had managed to pretty much upset our automobile apple cart here because their process management was so good. And it became apparent that healthcare, in order to really deliver the outcomes that people needed, required a lot more than knowledge, attitudes, and skills. The literature on harm to patients was filled with process breakdowns. And it was abundantly clear that we had created an environment for practicing the art and science of medicine on an individual basis with very little process management to support it, and that harm was coming to patients as a consequence. And so my career took a shift. So I left the residency program and came to managed care over at Health Alliance Plan and then Blue Cross. And the idea was to reconcile the goals of population management, where you have hundreds of thousands of members in your plan, and now you want to improve the care to them as a group. And there was a huge disconnect between the group and the individual, because population management is conceptual, whereas patient care is one patient at a time. And how do you bring those two together? And there, that was a real challenge, because you needed to do process optimization, but you also needed information from the group that the clinicians didn't possess that would help inform their care and improve the outcomes. And so my career really became focused on bringing information to the providers and creating organizations that could support the process improvement and standardization part of it, which was really quite challenging, because there really wasn't a lot. When we went into practices to actually map their processes, there was no process to map. And when we started to do that, we found that the thing that was happening more than anything else was interruption. People needed a prescription filled. People needed this. It was really a very chaotic environment to try to tame and organize in a way that could achieve better outcomes.
So what year was this when this paradigm shift for you happened?
It was approximately 1991.
1991? Yeah, okay.
Yeah.
Yeah.
And so the autos had already taken a shellacking in the 1980s, and everyone was asking the question, how can we restore our companies to preeminence? And we were examining what Toyota had done and the others to displace our big three. And so that was the sort of environment. And that was, I think it was around 1990, 91 that I moved over from running the residency program to managed care. So it was pretty far back.
Yeah. Yeah. So is there, can you give an example of what types of harm would be done to the patients in this kind of chaotic environment that through elements of the patient-centered medical homes, those types of things, when you had this cohesive group that were alleviated because data was being used to be able to guide what the patient decisions were going to be?
Okay. First of all, patient-centered medical home is an organization of a primary care practice, so that you have a relationship that connects the patient to the healthcare system on the one hand and provides individual care. And an example of a process that can cause harm is you have, and this was one of the ones that was being communicated widely at that time, is that there had been a patient death because there were vials that looked almost identical that contained different doses of potassium or digoxin. There were several examples where the nurse who was pulling the vial, and everybody's in this hurried, chaotic environment, pulls the wrong vial, gives a dose that's 10 times higher, and the patient suffers. And they realize that you simply cannot have these vials all looking alike, that you have to sort of read the fine print to know the dose. And so It was a process failure. And pretty soon they started completely changing how medications were packaged and delivered in order to prevent these types of mishaps. And that's one of many, many examples. But it wasn't that the nurse was being irresponsible. It was just that if the process is designed that way, somebody is going to be harmed. And we don't pay enough attention to those processes. But that was one of the things that drove a lot of process management back in those days.
Okay. So for the audience, could you be able to briefly describe what exactly is the Patient-Centered Medical Home Initiative? What was the start of that, and then how it kind of followed from there?
The patient-centered medical home has a lot of attributes, but I would sum it up by saying that the practice has to be organized in a way to take information in that allows more informed management of the issues that the primary care physician is facing. A lot of these are access issues. How do you get in to see the doctor? How do we manage access to the physician? Some of them are related to medication refills, and understanding of medications. And then it goes into how do people communicate with the other physicians engaged in the care of that patient, and how do you get information so that you don't have various physicians acting independently and sort of cross purposes. And so you have to organize how the practice manages these processes. And what we did is we basically realized that for practices to undertake all of these responsibilities, they needed to have an income stream to cover those, because they actually did use resources, and the manner of payment that we had didn't recognize any of that. So the payment process essentially starved out the devotion of resources to doing these things that could improve outcomes. So we had to understand that connection and modify the payment model. So the primary care physicians, right now, they have to look at a variety of things related to 20 different vaccines, related to other tests to screen for cancer, etc. And the information overload was very substantial. So we needed to have a system by which, at the point of care, the information needed to know whether or not a mammogram was needed, a colonoscopy was needed, a vaccine was needed, etc., that information was, as best we could do, presented and available, and then protocols were in place so that the physician didn't really have to order a flu shot every year. It was something that could be a standing order. And we got a lot better at delivering these services consistently. What we discovered, for example, with childhood immunizations, was that the people were coming in for their immunizations, but not all the immunizations that were due were being delivered because of this information breakdown. And it was very difficult for people to manage all these new immunizations that were coming around. They required different storage. There was just so much complexity to it. So the primary care physicians had to work very hard to sort of control this environment. And this is just the beginning, because, as you know, medical care can get very complex. And this is the simplest things. These are the things that, even if you don't have a doctor, these are things that are timed by a schedule more than anything else. And so that was the beginning. We found that the simple stuff was really plenty hard. It took us a number of years to get this thing working right.
So do you think about the time of actually starting this, the significance at that time? Did you have any idea the gravity that this would actually take in terms of what it's blossomed into? And I mean, it's an amazing architecture, and it's a bold idea. I mean, if you think about it, that you're going to be centering healthcare, what seems maybe obvious to patients, I think healthcare organizations centering everything around them and then using data to be able to guide that. It's, I mean, from where healthcare was to where it is now after this patient-centered medical homes, I mean, were you aware of the significance at that time, or were you even a little bit surprised in terms of what kind of change this had?
I did not appreciate how challenging and broad it would be. It was stunning to me how infrequently our first idea was a good one. We would walk into the room with all these ideas, lots of enthusiasm, lots of confidence, and we would listen to each other. We would be respectful, and we would all come back, and it didn't work. And I've noticed that Elon Musk says nothing works till the third try. And that was my experience too. It was humbling, but you just understood that what you were dealing with was just a lot harder and bigger than you had any idea. So it was a cold shower sort of experience, but it was also fun and was very collaborative, because we each had something the other needed. The health plan had information to bring, and we could support MyHIN, the Health Information Exchange, in getting the
Mm-hmm.
information to the practices, because we were hearing from people that their patients had been admitted to hospital and they had no clue. And physicians were saying, yeah, the patient was in the hospital 3 times and I didn't even know it. Then I'm seeing the patient after the hospitalizations, trying to figure out what's the best program to keep them healthy. And there's all this mountain of information that they were completely unaware of. And obviously that created challenges. So the information side of it, the organizational side of it, and the just what is going to work in this setting and was huge. So fortunately, I did have one thing that was good, and that is I had more 20 years to keep working at it, because it did take
Mm-hmm.
time.
So when you say that there's, 3 time is kind of a charm, did you see that momentum building? So after the first meetings, you see that it's kind of a rejection from one side, and then does it build? And it gives you that confidence that this is the dam's gonna break, so to speak? Or is it something that is kind of a surprise? You go in and like, oh, I guess now they are for it, kind of thing. So what was the experience like?
The experience was we never got to say huzzah, because
Oh, really? Okay.
we always found greater challenges, and we'll call them opportunities, um, than we ever expected going in. So we were never left with, wow, we can sit down and take a break. There was not an experience similar to the end of the U.S.-Canada hockey game,
Yeah.
where
Yeah.
everybody had the
Which was
celebration. We would
mhm.
celebrate small victories, but the challenges ahead were always bigger than the challenges behind
I
us.
see. Okay. So when you mentioned the financial model, so you established the Blue Cross Blue Shield Physician Group Incentive Program. That's the PGIP program, which became the financial backbone for the patient-centered medical homes, right? And so for that adoption to actually happen, how do you reward good clinical decisions without inadvertently reducing medicine to a scorecard? And I think this is the challenge that I'm really interested in how you keep that human side of it when you're trying to wrangle all of the financial aspects with these different types of players that are involved.
The answer is you don't.
You don't.
You don't
Okay.
do that. And people are doing that all over the place, and it's a mistake. And even
Okay.
Edward Deming in the process management in the auto industry didn't want incentives. He said they will kill the organization in order to achieve the incentives. The
Hmm.
healthcare providers are motivated. They want good outcomes for their patients. They have the energy, they have the orientation. They don't need to be rewarded to do it. They stand ready to do it. What they need is the resources, the
I see.
information, and the organization. And so the money always needed to go to supporting the improvement activity, so that they didn't have to sacrifice everything in order to get better. You had to support them that way, but it was not a process of finding out who was good and giving them rewards so that they could get better. That wasn't it. Whenever we
Okay.
saw a group of physicians, we did not bring our information to judge them. We gave our information to support them. And all these vendors out in the world today, they love this idea of risk-based contracting, where we're going to financially reward the winners and the best ones. And whoever that incredible internist is in Whitefish Bay, everybody in the state can't go up there and see them. We
Right.
need
Yeah.
all the providers that we have, and we need them to be better. And when you walk into a room with information to judge, you will have hours of people complaining that the information isn't accurate, isn't relevant, it's flawed, and you leave the room accomplishing nothing, including not creating a relationship to build on for the next
Right. That
encounter.
makes
And
sense. Yeah.
so it's astounding how many people still get stuck on thinking it is an incentive for people to do better, when it is really resourcing the ability to improve.
Mm-hmm.
And that's not widely appreciated. And I think we've gone backwards in many ways because the consultants are really, really into this risk-based contracting to reward the better ones. And what it means is it starves out improvement from the others. And the people who are already good can get rewarded, but that doesn't mean that they get better.
Yeah. It's almost it's funny. There's a book that I'm reading by Ken Segal about Apple. He was a marketer for there, and it's called Insanely Simple, and it just talks about Apple's process of keeping things very, very, like a small group to be able to decide. Don't have people in your meetings who don't need to be there. Just these types of things, and it seems like what you're saying is kind of have the physicians be able to discuss what's going to be the resources that they need to make sure that their patients stay the healthiest and give them those resources. And that's really the basis of it. It doesn't need to be more complicated than that, right?
Right. And the other thing is
Mm-hmm.
the out there among the many, many people practicing medicine, there is variation in approach. Some of it's based on style, some of it's based on where they train. There's all sorts of reasons for the variation, but the variation is
Mm-hmm.
there. And one of the things that was critical to process improvement was studying and measuring variation and trying to understand it. And we've sort of gotten
Mm.
sidetracked into disparities as opposed to variation
Yeah,
because
that's true.
we don't understand what is causing the variation. So when we were looking at improving the outcomes of hip replacement, we got all the physicians essentially together who were doing the hip replacements, and we looked at what hardware they were using and so forth. And it was actually that we were providing the information that allowed them to look at it. And they found that there was variation in the outcomes of the surgeries. And they found that the people who were using the sort of standard approach achieved the best outcomes. And all these people who had sort of taken a different approach were suffering worse outcomes. So they talked to each
Mm-hmm.
other and they realized that if everybody got together and made their processes more uniform, that standardization allowed them to speak with each other more coherently and to actually improve more. And they substantially improved the outcomes just from understanding the natural variation. And there's many, many examples of this. I was in so many meetings where, for example, the people who were going to do bowel surgery, they needed to give antibiotics in order to prevent postoperative infections. And some of the people never had postoperative infections and others had high percentages. And then I see them in the room saying, what do you give? And I give this in this dose. He said, I didn't know you could give it in that dose. You do it that way? Yeah, we do it that way. We never run into problems. And the next thing you know, the whole state is on a single protocol that reduces the postoperative infections from these surgeries. And
Mm.
so you can see an incentive program would never have achieved that. But
Yeah.
getting the information and the support for those conversations does. And that, when you think of diabetes, for example, it's unbelievable the new medications that have come out to address the issues of type 2 diabetes. And I can just look at it and say, oh my Lord, the variation in how people are using those medicines and what success they have. And I go to organization after organization and say, are you looking at this? What are you discovering? What's the best way? What works? Nobody's looking at it because this analysis of variation and then just asking people who do it differently and looking at how those differences are associated with different outcomes is something of a lost art. It's
Mm-hmm.
that type of analysis is sort of succumbing to the people who do the scorecards that you mentioned. And so the
Yeah.
scorecards are proliferating and people are getting paid by how good they look on the scorecard. But the analysis of variance and learning from each other is just hard to sustain because it is kind of resource intensive, but it is by far and away the best way to improve things. That's where we saw the real gains.
Okay. So you mentioned diabetes, and I guess with managing chronic illnesses, both hard data and genuine human compassion, their best outcomes happen when both of those take place. So you don't want to sacrifice either one of them, right? And so, can you share an example of where data tools improved a patient's life in a way that numbers, weren't actually there to be able to describe that? So essentially,
Well,
different things that you would have with clinical decision support types of things, I guess is what I'm getting at with this type of thing. Being able to make certain types of decisions that the data tools had. And essentially the numbers alone couldn't really tell the improvement that you as a physician were able to see.
well, the best that we were able to do was to show that genuine harm, such as a postoperative wound infection from a colon surgery,
Okay.
is absolutely, in anybody's experience, a horrible outcome. And then you can actually see that by changing how they pre-op the medication, that they reduce that very significantly. You do see patient outcomes that are inevitably attached to that. Same thing with hip replacement. Nothing worse than a failed hip replacement or needing to do it over again. And there's our window into seeing the patient reaction was best, I think, tied to those types of outcomes. We did do surveys related to patient satisfaction, but they were so multivariate, and so it related to parking and access and a bunch of
Mm-hmm.
different variables that we never were able to use that tool to really
Okay.
sort out all the variables that go into it. But we certainly could tell when horrible outcomes were averted.
Okay. That's good. So I'm really curious about the reimbursement part, just to kind of go back to that. So you oversaw reimbursement for 25,000 plus physicians. That's a lot of physicians, and I know that even since you've retired, it's grown much more even with that. But how effectively, I guess in terms from a conscious level, were you of that power that you had with being able to do that, and how did that help you steer the different types of decisions that you are making with reimbursement for the state of Michigan?
Well, it sounds like there's power there, but I will tell you that there's never enough money, number one. And number two, there
Mm-hmm.
is not enough money in the kingdom to get people to do what they don't want to do. And
Yeah.
so the physicians do want better outcomes. They do want happy patients. They do really care about their patients. They do feel overwhelmed at the end of the day, because I already described
Mm-hmm.
how chaotic the day is and how challenging it is. And they don't respond well to coming in with data where people are challenging them, saying, we're judging you negatively because we don't like your numbers.
Mm-hmm.
And because every day they're working as hard as they can. They really care about their patients. When a patient has a bad outcome, they feel terrible. They really are invested in the well-being of their patients. And then for you to waltz in from the insurance company and say, oh, we're going to pay you less because we don't like your outcomes or we don't like your numbers, that achieves absolutely nothing. And I'm afraid that there are not many advocates for doing it what I would consider to be the right way, which is using the money to support people so that you can measure improvement in the overall level of care. So
Mm-hmm.
a lot of what is happening over the last 5 years is that the consultants are urging a lot more prior authorization, because prior authorization, which is where you get permission to perform a
Mm-hmm.
procedure or a test, it only benefits your own members. And the criticism of the way I was approaching it is that it raised all boats. The people who were not
Okay.
getting the infections, it didn't matter what insurance they had.
Mm-hmm.
And so what happened was it was difficult for people to see how doing the raise all boats really benefited the payer. So there's been a retreat from this approach, and there's a lot more. We're going to put you in a payment contract where if the outcomes aren't as favorable, your money is less, and when they are favorable, the money is more. But that isn't working very well. I don't know if you've noticed, during the period 2000 to 2020, the information that I saw was that Michigan had the fourth lowest healthcare cost increases of the states, of the 50 states. And since that time, the costs have been going up quite a bit. And it was just in Cranes this last week that
Mm-hmm.
that Blue Cross lost $1 billion and sold the Accident Fund because healthcare costs are just increasing way too rapidly. And I think that that's what happens when you sort of don't choose to raise all boats, because there's no other way to do it. Process
Mm-hmm.
consistency and process management cannot succeed by giving different care to people with different cards in their pocket.
Right. Yeah, it seems so. This kind of goes back. How would you relate this to essentially where that distinction between fee based and value based is really set? Because again, from the insurance company standpoint, being able to take 7 X-rays on something that only required one, would be able to feed back into that. And so, if you have somebody based on their insurance, what kind of different types of care that they're going to be getting from the healthcare organizations, how do you swing that so that the payers or the insurance companies themselves would find benefit in that, raise all boats, that entire population of type 2 diabetes, as you mentioned, would all be able to benefit from that? Do you have any insight in terms of how that would be approached?
Well, I would approach it the same way Deming did,
Okay.
back in the 1940s. And that is,
Mm-hmm.
you look at variation in performance and you separate it into common cause variation and special cause variation. And common cause variation is something where you work on improving. Special cause variation is when you have the sort of bad actor, the 1% to 3% who
Mm-hmm.
literally own an X-ray machine and are using it in an irresponsible way. And your data can show you the difference between special cause variation and common cause variation, and you treat those problems differently. If you try to take the approach for special cause variation, which is basically the extreme 1 to 2, maybe 3%, and try to
Mm-hmm.
apply those principles to the 97%, you will not succeed. Similarly, if you try to take the principles for the 97% to the 1 to 3%, those don't work either. And I don't believe people are skillfully limiting their what we called sort and shoot, which is the way you treat the special cause variation, the extreme people who are the bad actors. You want to treat them completely differently. And what I'm seeing is people aren't limiting the approach that works with special cause variation to those instances, and they're applying it to the rest of the curve. And that didn't work in the 1940s, and it won't work in the 2020s.
Yeah. Do you see this as an opportunity more for healthcare organizations to be able to get individuals who are much more in terms of biomedical data science or health informaticists who can draw out what those variation differences are and make them very easy to be
Oh,
able to
do I?
understand?
I think you just hit the most compelling need that we have. I go from organization to organization, and they have not made the investment in analytic capabilities so that they can understand the differences in practice in their own organization. And that, I don't care whether it's University of Michigan, Michigan State, I'm sure it's different in Michigan Tech, but the idea
Yeah.
is I see that as a crying need everywhere, and it's just almost universally absent. That analytic support to understand the variation, talk to the people involved in it, and get their ideas as to what are the causes of that variation, and then
Hmm.
use the differences to share among the participants what are the things that are associated with best outcomes. You don't need to incentivize them to do that. If you think, I mean, going back to the infections post-operatively, do you think the surgeons need an incentive to not have to deal with going
No.
back in to deal with that? So they don't. And so I don't think I can identify a single more important need than what you just described, which is the analytic talent to be able to organize the data effectively to answer those questions of what variation do we see, how do we explain it, and how can we turn that into improvement.
So I don't want to put you on the spot, and I want to preface this that what the question I'm going to ask you right now is not going to be dictated as on the record or set in stone type of thing. But what type of ROI would an investment of a healthcare organization, let's say a substantial healthcare, I'll just take us outside of Michigan right now and just say like, Cleveland Clinic or something like that, something like if they were to be able to have those investments in it, what kind of ROI could a healthcare organization expect to be able to, and this would be from a fiscal standpoint, not from the aspect of, for example, maybe happier patients, happier employees, clinicians. But is there a big ROI? Is it significant in terms of what could be done from being able to draw out those variations correctly?
In terms of the value derived, it's extremely large, but it has to depend on the payment model. So
Okay.
just as we went with patient-centered medical home, if you, let's say that you take an office visit or an annual exam, let's say that you were paying $100 and then you go
Mm-hmm.
up to $130. So you make a big increase in it. That doesn't incentivize you to bring on extra people to look at the information so that you can do a better job. It incentivizes you to do more annual visits, and it permits
Mm-hmm.
you to use more resources to deliver that better. But you've got to connect the payment model and the strategies for doing well under it. And
Okay.
and so it really is a partnership. And if you look at Medicare Advantage was set up, I think, probably over 20 years ago now. In fact, it was longer than that because it was called Medicare Part C, and I was taking care of Medicare Advantage patients under that program in the 1990s, and they established two major priorities. One was called STARS measures, which
Okay.
are various quality measures and so forth. And then the other one was how sick are the patients you're managing and how you code the illnesses that the patients have became the focus. And what they did is everybody poured all these resources into managing those two things. And those two things got done. But the cost of care and the quality of care didn't budge. It
Mm-hmm.
didn't budge because when you try to reward specific things, you reward specific things. And so you
Mm-hmm.
need to have a contract that enables you to use the information that you can collect on a population, study the variation, get the people together, and that then you can derive the advantage of the improvement that occurs when people adopt the best practices from
I
within the
see.
group. And so if you have the right payment model, now looking at it from a can you bring the cost of Medicare down, the answer is you can bring the cost down very substantially on an annual basis. by doing that, because there's a huge cost associated with bad outcomes and missed opportunities and failure to provide these best practices. But it also
Okay.
allows people to live longer. And
Mm-hmm.
so if you're looking at the Medicare funding for the long term, you're getting way better value, but the government isn't going to see a huge dividend, but the people will. The
For sure.
people who are
Yeah.
living longer will. But you do have that thing, because a lot of people succumb to their complications. And and it's always been an observation that people make, is that, well, that really makes them cheaper for the government. Um, and it does, but so it does affect the numbers a bit. But yes, you can bring the cost of care down each year for each recipient. One of the examples of that in terms of value is uh, end of life care.
Okay.
End of life care um, tends to follow community patterns. So if you look at Marquette and you look at Detroit and you look at Grand Rapids, what you will find is the providers in each of those communities fall into a certain pattern set. And so it's one of the few things where things are organized on a community level. So it's kind
Mm-hmm.
of it's kind of different. But one of the biggest opportunities in medicine is not continuing to oppress people in their final weeks and months with medicalizing everything to their extreme detriment, and allowing
Mm-hmm.
people to understand the choices that they do possess and the latitude that they possess to actually manage to maintain their own agency, their own ability to decide, this is what I want to do. And we still do not do a good job on that. But 25% of Medicare funds do go to people in, I can't remember if it's the last year or the last 6 months of life, but you can see in that time frame a lot of expensive harm coming to patients. And I would say that that's a major opportunity. I think everybody can think in their own family how
For sure.
there were
Yeah.
individuals that they would have loved to manage it differently, um, and I'd like to see a lot of improvement there.
And this is where you would see some of the variation being excelled. And okay. Yeah.
I remember a conversation that I had with the daughter of a patient, and this is a patient who was in a nursing home, severely demented, meaning they were literally relegated to bed, could not hold a conversation. But
Mm-hmm.
the patient kept coming into the hospital repeatedly for either aspiration pneumonia, where that because they weren't very with it, they were swallowing down the wrong pipe, so to speak, or bed sores getting infected. And I was talking to this, I was on call for somebody else, and it wasn't my patient normally, but the daughter had been managing her mother's care as a full-time job for the last 5 months, and she was totally exhausted.
Mm-hmm.
And I had the conversation of, what are the goals for your mother? Do you want to extend her life, or how do you want to approach it? Do you want her to be comfortable and dignified and clean? What do you want? And she just started crying. Was so overwhelmed with her whole life being taken over with these absolutely pointless admissions that she literally said, I never knew I had a choice. And she was amazed. And she said, my mother doesn't need to live longer. She needs to have the dignity, the clean,
Yeah.
comfortable, dignified. And that's how we managed it. We didn't give the life prolonging therapy. And all I could think of is, how many times does this tragedy play out? I've seen it so many times. Patients who were in the same situation, then I get a call saying they want to put in a pacemaker because they notice the pulse is low. And I said, well, the pacemaker is a life prolonging therapy. Your mother will
Mm-hmm.
not be more comfortable, more dignified, nothing else. If that isn't one of your goals, then why do a procedure, bring them into the hospital, go through a procedure that isn't in advancing one of your goals. And again, they felt liberated by the idea that they had a choice. And I just see so many times where the system takes over because we can do it. There's a pressure to do it, and it's not working to people's advantage. And too many people are essentially
Yeah.
dying in the surrounds of a medical procedure rather than in the surrounds of their family.
Yeah, I mean, I think, from a standpoint, a lot of people, and I can say in my family, it's true as well. You feel like I know from my parents, sometimes, I'll go with them to different appointments because they don't feel like they can be advocates for themselves. And it's, sometimes decisions they feel like, well, maybe it's nothing not the decision I would have made, but if it's coming from the healthcare organization, I should do it. And it's completely contrary to what they want from their quality of life standpoint as well. And those are the things that there's definitely a culture where it doesn't seem like it's a front facing, let's go ahead and have you try to manage it, you and your family, as best as possible. A lot of times it comes through in terms of, these are the directives that you're given, you need to go through these steps. And that's something where variation can be able to show that maybe those are not the correct steps, right? In terms of some of those instances, and to be able to give people the dignity and those types of things, as you mentioned, that sometimes, which is horrible, that they don't get towards the end of their life. So, yeah.
And
Um,
I had the same personal experience where my wife's mother was in the hospital, and she had very clearly stated her intent, but
mhm.
she didn't speak English, and so uh, they wanted to do everything because they didn't have a translator in the room. And they didn't
Yeah,
trust us to translate for her. And it was like, good Lord. It fortunately worked out, but it was, the momentum is with do it, because you can never look back and say we're criticized for failing to do what we could have done. And that
right.
momentum is something that it does require both um, the patient and often a family member to support them through that.
Okay. Yeah, yeah. I mean, it's you seeing that. I mean, myself with my family, but for you seeing that on, from a physician standpoint, and to see how liberated, as your words were, in terms of somebody who's just completely exhausted. I mean, that's probably just what they needed to hear, to be able to, not only be in line with their core values of how they want to be able to address the end of the life for their mother, but also to be able to take that burden off of them, which must be somewhat gratifying, even though it's a very tough situation for the physician itself, right? So, yeah,
Yeah,
just
but
having
it
that
was, to me,
flexibility is
it was very
important.
rewarding because you can't, what, at some point there's just no recovery.
Hmm.
You have to actually understand the situation and deal with it rather than supporting false hopes that are unrealistic and cause you to go down a path that causes more harm than good. And for each patient, they haven't necessarily been through that path before, but for the caregivers, it's very clear many times that pursuit of the medical model, when past the point where their body has anything going for it
Hmm.
anymore, is just so futile and creating such burdens on people. It's really astounding.
Yeah.
It's
Okay.
also an area that you don't want the incentives to be governing it. You want
Exactly.
the money to be going into supporting the care process that allows people their agency to make their decisions rather than um, depriving them of that. And
Hmm.
um, and so we're not there yet. That's why I say this thing keeps getting bigger and bigger and bigger the more you
Yeah.
you work with it.
Yeah. Yeah, I can see the complexities. It's yeah. So I want to switch a little bit into maybe a little bit more lighter, just for a moment.
That won't be hard.
Yeah. To be able to get into. So this is the part where it's basically called pulse check. It's just some really quick questions and just kind of rapid, response as much as you can to it, just to kind of get to know a little bit more about you. So first one, coffee or tea? Which one?
Coffee. Coffee,
Coffee.
except when I'm
Now,
sick.
so with coffee, does that give any indication of your leadership style? So if it's coffee that's black, for example, then maybe it's no nonsense. If it's coffee with sugar and cream, maybe it's a little bit more humanistic aspects. Does it reflect your leadership style, or does it not reflect your leadership style?
I tend to, well, I'm not positive of the answer to that. I can say that I have um, relatives born in Asia who drink tea.
Mm-hmm.
So I think it must be cultural for them. Um, I like to sleep well at night, so I don't drink any coffee except in the morning
Okay.
and that kind of thing. But coffee has changed the world. I read a book on coffee, and basically it said that before that, people were drinking sort of weak beer, and then everyone got on coffee, and the next thing you know, the Renaissance hit, and they were building all these great things,
All these
and
things, yeah.
Europe changed, and
Mm-hmm.
it was basically saying the world changed because coffee came to Europe.
So
So
does it?
I look at it that
Do
way.
you consider yourself a decisive leadership style? Are you more humanistic in terms of what kind of leadership style do you normally feel like you categorize into?
I think I'm not sure exactly if there's a name to it, but I like to get people in the room and leverage their experiences, their enthusiasm,
Mm-hmm.
and information that supports them in what they want to do. It's never been successful for me to walk in the room and try to get people to do what they weren't inclined to do or anything of that nature.
Yep.
So in this particular thing, I think command and control. It's not like the physicians are my employees. It's
Right.
not that I would treat
Yeah.
my employees that way either, because, but the point is, when I worked with people, I was working with people who were there for a reason other than I called a meeting of the people who were employed in the department type of thing. And
Mm-hmm.
so healthcare is of that nature. And if you try to treat it with command and control, you usually end up with failure, pure failure.
Yep. What's the best piece of advice you've ever been given?
Maybe when I had our first kid, that our life would change.
Okay.
I do
Yeah, that
remember
is a
that
big
one.
one. Yeah.
But one thing was, I was walking with a friend, and um, I was talking to him about the fact that there was this applicant who was saying how much she wanted to work for me, and she'd heard me talk and everything like that. And he turned to me and said, "Tom, she's only saying that because you're the vice president and you have what she wants. Don't take that praise
Mm-hmm.
to to heart." And I did realize I didn't realize I was so susceptible to buttering up, and but it was
How do you think
obvious
I
to me.
got you here on this podcast, Tom? I'm just kidding.
Yeah, right. But
Yeah.
I that was a
Yeah.
big insight for me, because I it never dawned on me that I was
Mm-hmm.
just as much of a dupe to that as the next person.
Yeah.
And it did teach me for my subsequent years, don't, think about that motivation.
Yeah. Yeah. I mean, everybody has different things that they're susceptible to. I've been surprised at mine as well. So, and I would say when you do have a child, that particularly your first child, you do notice not people will say, oh, your life won't be that different. It's way different with children. But I would say leaving the hospital was when I noticed it, because I was extremely critical from everyone else driving just from leaving the hospital. In fact, we got to the 4-way stop sign and somebody basically just, didn't come to a full stop, just kind of rolled through, and, and before I wouldn't even think twice about it. And it's like, what are you doing? There's a baby on board, like just complete mind has changed. And so I'm just, probably like a couple of months off of, telling somebody to stay off my lawn, one of those kind of people who are like, get off my lawn. Yeah. So I think from that standpoint, yeah, it's very easy to be able to have things that are significant in your life change your mentality on things or change your outlook on things. What is the most, I don't want to say this, what is the medical policy that has been probably the most impressive that you've done, or maybe the most gratifying medical policy that you've been a part of or originated, that you're proud of, essentially?
Well, you mentioned the patient-centered medical home, and I
Yep.
think that probably was the single most important thing because it sort of set the stage. But it was kind of interesting because one of the leaders of the physicians organizations, Eva Matashevsky, contacted me and said, what are you going to do about rewarding patient-centered medical home? And I'd never heard of it. I had heard of the chronic care model and a few other things. I had never heard of patient-centered medical home. So then she invited me to give a talk about how we at the Blues were going to foster and support patient-centered medical homes. So then in order to give the talk, I had to study up on it. Mm-hmm. And it was very clear that if this is what the doctors, how they wanted to organize their practice, that this was something that I could work with, support, encourage, and help direct it so that I could verify that whatever money Blue Cross spent on it was going to be returned to Blue Cross customers as a good deal, a value for them. And so I think the main thing was that my biggest career achievement was absolutely not something that was my idea at all. Taking the good ideas of others and allowing and supporting them to run with it is a far more successful way than coming up with any good ideas. Mm-hmm. And so I came up with fewer and fewer good ideas the more I realized that nobody was interested in doing my good ideas as much as I was, and nobody was as interested in doing their good ideas as much as they were. And you mm-hmm. had to tap into that enthusiasm. Now, there are some people who are just interested in a career change and they want a lot of money to do things. And every now and then you have to sort that out. But most of all, it's running with the good ideas that the people in the room have. Okay. And recognizing the people who have the variation that shows that they're doing it better. They're getting better outcomes and having them share their best practices. That's obviously something they like.
Right. And so basically making sure that everyone's input is going to be strategic, right? In terms of the entire plan of what's going on. Yeah. Yeah. So without naming anybody, because we don't want to name it, like, I'm just curious because you've been in so many high profile meetings and those kind of things. Was there anything that sticks out as something that was extremely funny that happened in a meeting that you've had throughout your career? That, I always go back to like the Seinfeld episode of, where George leaves the recorder in the briefcase to see what they're saying about it when he leaves, with that one. Was there any type of incident that you can recall as like, man, that was really funny?
Well, I did have one. I was at work and I felt bad. I was starting to feel feverish. And so I closed the door to my office and I lay down on the floor on my stomach, and I was just trying to fall asleep. And I had an associate vice president who taught me how to write. She literally took everything I wrote and she took red ink and improved my writing skills. It was like the best thing. And so she was coming in with my improvements, and she just opens the door and sees me crashed out on the floor. And she goes, oh, and she just panicked, and that was the funniest thing, but that I recall. But
Yeah.
I was just shocked. I was glad she didn't faint on top of me because it was very close to that.
Yeah. Traumatic for her.
Yes, absolutely
Probably,
traumatic for
right?
her.
Yeah. Oh, that's funny. Well, funny now that you're feeling better, but yeah.
Yes, right,
Um,
right.
right.
I'm sure I was fine the next day. It wasn't real serious, but it
Yeah.
was.
Yeah.
I was
So
so
you
grateful to
went
have a
to,
floor to lie down on that was carpeted.
y-
It was
yeah,
not
no, I've
bad.
been sometimes, yeah, when something hits you like that, you don't have much choice. Where you are is where you are. So,
Yeah.
so you went to both University of Michigan and with medical school at Wayne State, right?
Yes.
Which one gave you more?
Well, it was a different sort of experience. I loved both places, and um, I still love both places. But it was a very different thing. The University of Michigan, I got there, and the first semester that I was there, I had a statistics professor. I took statistics, and they had a statistics professor who was probably 78 years old. And they had these just long-standing old professors who were just brilliant, and I just enjoyed every minute with him. He says, "Oh, let's examine this just for fun," and
Hmm.
it was like making statistics to him was just plain fun. And I just had all these sort of legendary people who had magnificent careers, and it was just a joy to be in their presence and to just see them at work. And they were sort of from a different era. He was talking about how when he went to Michigan, you didn't have to lock your bike and this kind of thing. And it was just such a good. And we also had another guy who they made a rule saying you can't smoke in the front of the class. So he was my professor, and he walked in front of the class with an unlit cigarette in his mouth the whole time, and he would take it out of his mouth and put it back in, but he just couldn't light it anymore.
Hmm.
And he was a magnificent history professor and so forth. And then we had. So to me, just seeing these fabulous people teaching you was such a joy. At Wayne, I didn't have that same experience, but oh my goodness, the experiences they were able to offer because the clinical surrounds just offered every sort of experience that you needed to have. And in many cases, you felt that if you weren't actually the one dogging the care of that patient, that there was nobody who was really looking after them as closely. And so you felt as a real participant in a positive way. And so I felt that it really gave me that hands-on that I enjoyed so much. So both of them had their own way of doing things that was great.
Yeah. And they have such a friendly rivalry with academics and athletics. I thought I would kind of just ask that question. Yeah. So what about from a book standpoint? You mentioned that you read the book about how coffee changed the world. I was wondering, is there any book that you would recommend to, whether if it's medical or otherwise, for a clinician or somebody into biomedical data science, just any book that it could be philosophy or any types of things that really made a profound impact on you that you would suggest or recommend other individuals to read it?
To tell you the truth, most of them are out of print because
Oh, that's okay.
back, what's that?
Yeah, that's. I
Oh,
mean, just to know what book that you think would be.
well,
I've always, yeah.
there's a number of books that I just consider
Okay.
to be just treasures that I read, and but they were a long time ago. And the Deming books, the
Yeah.
back in the 1990s, managed care was in an explosive heyday. Everybody was talking about it. I must have read 20 books, and the Deming books, Out of the Crisis and a few others, were sometimes hard to get through because they were 600 pages long, but they just were filled with so many anecdotes. And it changed my perspective on things. Another one that I really think is good, but it isn't really related to medicine. The two that are not related to medicine is Out of the Crisis by Dean Acheson, the Secretary of State under
Oh
Harry
yeah.
Truman, who
Mm-hmm.
created NATO. And NATO's been in the news lately. We're all sort of rethinking
Mm-hmm.
it. And the perspective that I have looking at all these events related to European security, I go back to my thinking of that book, Out of the Crisis by Dean Acheson. Unbelievable. It was all herding cats. All the Europeans were just suspicious of all the other Europeans, and nobody wanted to come together in any sort of common thing, and so forth. And then the third one is Barbara Tuchman's Guns of August.
Oh, Guns of August is a great book. Yeah.
Oh, I've read it like 3 times, and it is just a great book. It just makes me think of history differently. And when people start talking about the end of history, I keep thinking, no, if we could ask Barbara Tuchman today, she would have a great answer for that.
Yeah, I think Guns of August is a terrific book for people to really. It's for me, it was a very mind-blowing book in terms of how things are actually approached and what is actually going on. So it's the different types of incentives for different individuals and how they portray that is really interesting. That's one I'm not familiar with. I mean, the Deming books, yeah, but what was the one with Atkinson? I'm not familiar with that book.
The present at the creation was Dean Acheson, the Secretary of State under Truman, and that's out of print as well. But like I say, NATO is a big thing nowadays. People are talking about it and what it should be and what it isn't, and what this kind of thing. And all of those issues were present at the creation of NATO. and it was never any different. And we keep thinking, oh, this is new. All of a sudden, NATO has these issues. And he said, well, those were the very issues it was born with in like 1947. And so it was, this is just what you have to grapple with, the challenges that you always face. And so I think that what we talked about today in terms of how you work with people to achieve better things, NATO could, and if you look at how Dean Acheson approached it, he approached it much more collegially and collaboratively. And time will tell whether or not that achieved a better outcome. But to me, that was an amazing book because so many observations over the years have me thinking back to it.
Mm-hmm. Yeah, it's amazing how things come full circle. Many things, become full circle. So if you weren't in medicine, what kind of career would you have chosen that you think still would have brought you some joy?
Well, that's a good question. It all depends on talent. Like I feel that with medicine, that combined interest and talent. Now I would really like engineering, but I'm not sure that I would be bringing as much talent as I am enthusiasm to it. I have a son-in-law who's an engineer, and it sort of has exposed me. And when you look at the tech revolution and so forth, and how things are really going to be changing, and I like to keep up with the new electric batteries for cars and so forth, and how much innovation there is there, and how that innovation is going to sort of achieve huge breakthroughs for our lives. So when I built a place on Lake Huron, I built it so that it had towers that could house windmills, and I had the roofs facing south for solar panels. I'm just waiting for all these developments so that the technology sort of matures, so that I can sort of take it. I just would love to have an electric car, but I still have to wait till my car runs out, so to speak. So to me, engineering would be the second one.
Okay, that's great. And then what hobby brings you the most joy that you have right now?
Well, I like putzing around on Lake Huron.
Oh yeah, that's a good hobby.
Yeah, I just love. I landscape, I garden, I do a lot of things there. I've got a lot of grandchildren who come in and do stuff. So the grandchildren would probably be the big thing. One thing I can say that when I was in my earlier days, when I would go up to Lake Superior, um, and I would try to take a dip in the lake before I had my clinic. And I remember one time, this is in the summer, going into Lake Superior. It was so cold, I could see my breath when I breathed out, but I still had to get
Hmm.
under that lake. And so I like bobbing around in the lake.
So no sauna to preface going into the lake that time?
Maybe someday. I hear there's all sorts of
Okay.
health benefits. And so
Yeah.
I, I don't like the idea of using up a lot of fossil fuels to keep me toasty and everything. So I'm hoping, I was sort of hoping that would come after I had some power walls and some
Hmm.
alternative energy source. But yeah, that appeals to me, and it would be a
Yeah,
great
it's pretty
foil for the
common up
lake.
here. Yeah, it's pretty common here. You jump off the dock, you go back to the sauna, and then you do that about 57 times, and then you're tired, kind of thing. But it's yeah, I'm not into the like polar bear types of activity, the polar clubs and things like that. In terms of, I don't like the numbing cold of Lake Superior. Like, to dive in and come out, it's okay, but I would do that in the summer. I wouldn't do that in winter events either. But
No, I wouldn't,
yeah,
and it's
it's
not really healthy either. The
yeah,
sauna is healthy; it increases your heart
yep,
rate. It's associated with sort of physical benefits, but
in
the
moderation, right?
fins.
Yeah.
Well, actually, I'm not sure exactly what the limits are. I've seen some podcasts or of people who literally are getting close to the boiling point, and they have ice
Wow,
packs
really?
lodged in different places, and
Oh,
they are
okay.
convinced of it. But
Yeah.
the thing that I don't really approve of is going from hot to immediate cold, because there have
Mm-hmm.
been people who've sort of blown out their left ventricle because the blood pressure increase is so rapid that
Quickly,
not
yeah.
everybody's heart can take care of it. So I'll go with the warm after the lake, but not
Yeah.
ruining the warm by going back in the lake after that.
Yeah. Okay. So if we just kind of get into some of the portions about AI and healthcare, and there's an enormous amount of excitement, but there's also an enormous amount of fear about implementing AI into healthcare organizations. And so from your vantage point as a physician, a payer executive, and somebody who watched technology essentially reshape the delivery of healthcare, where do you see AI genuinely augmenting a clinician's ability to do their job better?
Uh, AI to me is a tool, and
Mm-hmm.
it has to be understood in layers. So you don't want a surgeon who has just met a new way of replacing aortic valves to understand that only superficially. They need to understand blood flow, heart dynamics, as well as structure and so forth. They need to understand it in a lot of dimensions. And one of the things that people often have with data is sort of, if you read off the AI conclusion and you don't know what's under it at all, and sometimes it's impossible to know what's under it, but you can at least look at the data that shows that it's reliable. I think you're going to be helped a whole lot more than if you follow it without adequate scrutiny. And so we have to be careful that way. But that being said, I think it offers a big help to us when we're using it in a more sophisticated way. So, for example, reading electrocardiograms. When I was
Mm-hmm.
in practice, the computer read them, and it was a joke. We used to always laugh about how the computer got it wrong, because they would take any sort of motion artifact and interpret it as it was happening in the heart, when it was the leads were off or something, or jiggled. And I'm told by clinicians now that the AI based interpretation of that tracing is really very good, and
Hmm.
you only go against it with real firm knowledge. And so I think that where AI has gotten to that level where it's actually better than the human version, we need to incorporate it. And then of course there's all sorts of shades of gray, and then there's areas where it just isn't right for that challenge. But I would embrace it and encourage people to use the tools, but really understand it from a variety of dimensions and layers.
So essentially, just making sure you're removing the automation bias, where they're just, oh, that's what the AI is telling me to do, so that's what I'll go ahead and do. I mean, is there? Do you see the AI portion as, are we moving too fast? In I mean, over the last 5 years, it's been really so significant in terms of how much progress has been made with AI. For that to be able to continuously step into the healthcare organization, is that a concern? Is that organizations are going to move too fast, or do you think that the guardrails are set up that they could be able to implement that and really serve the patient better in terms of their overall goals?
Well, it has a risk of being done too fast by the people who just plain implement it without understanding it. And I do think it's going to have the same approach that I mentioned earlier. That's that your third try that
Hmm.
works. So don't look at it and just walk away claiming all the benefits. Examine to see whether or not it actually is delivering what you expected from it. Because all of my and when you have somebody like Elon Musk saying that, he's obviously somebody who works a lot in AI. And we had examples of where people used AI and they weren't careful about the data sets that it exposed the AI to, and the AI made some really really stupid mistakes that no human would
Hmm.
ever make. And that's because the information that was fed into it. And then I have personally, within the last month, seen these AI YouTube videos where they literally had the person's head facing backward on the body type of thing. I mean,
Hmm.
it was just they created these images, and it's famous that there's five-legged elephants and so forth. And there was a three-armed man, this kind of thing. So you need, like with anything new, you really need to watch it carefully, but don't shy away from it. But don't
Okay.
just implement it and walk away. You've got to watch it closely.
And essentially, this is, I'm assuming, would be the same support for variation tracking that you would have on the different types of decisions that were being handled by AI, and being able to work towards the standardization, as you mentioned, with the patient-centered medical home. That standardization was able to be a catalyst, right, for other people to be able to change their ways to make it improve for the patient, for themselves, and the
That,
organization.
I think you brought up an excellent point. AI has been known to sort of confabulate by
Hmm.
connecting 2 points and imagining that they're connected a certain way. And when you're looking at variation, you don't know why. That's why I don't like the word disparities, because that implies that you know that it's some sort of dynamic behind it.
Hmm.
When you see variation, you don't know the dynamic. If your AI is confabulating the dynamic behind that variation and it doesn't really know, you've got a problem. You have to really look into it and ask this practice has 60% of its patients with type 2 diabetes on metformin. This practice has 6%. And then it may turn out that the way you start the medicine, that the starting dose, because metformin takes a long time for people to adjust to it, it
Yep.
has a lot of side effects. And so what happens is if the people who are starting it at full dose can't get people to accept it, that's wonderful. But you can't just assume you know the answer. You have to dive deeper, and you got to be careful with AI, because sometimes it is designed to draw conclusions prematurely. I mean, so
Hmm.
far, and they may be correcting that, but that's something that's been observed.
Hmm. And I think that's part of it. I mean, some of the things that we're doing, even with large language models designed for different types of clinicians to be able to ask questions about their patient or their patient population. Once it comes up, for example, how many patients have a BMI over 30 that haven't been diagnosed with type 2 diabetes, something like that. It will be able to not only show you, who these list of patients are, but you can also click on where it's actually pulling that information from. And I think that the next part that we're trying to do is visualizations on the fly. So how can those connection points be visualized so that a clinician can easily be able to interpret what the model algorithm itself is actually doing? We're
Can
not there
I?
yet, but we're working on that. Yeah,
I'd like to suggest my favorite question to ask
please. Okay.
is for patients with diabetes at the practice level, what is the average weight change from year 1 to year 2 to year 3? And you're going to find practices where the type 2 diabetes population in the practice has gained weight, has stayed the same, or lost weight. That's the
Okay.
variation that you'll find. And the question is, what are the differences in outcomes when you compare those groupings, and what are the things that are being done differently by the people whose population is losing weight? Is it all Ozempic? Is it all
Mm,
lifestyle? Is it metformin? The thing is, we all know that weight has a significant role in type 2 diabetes. And so it's just a matter of if we should be managing it. I have not yet seen anybody who has actually looked at the variation in the weight by practice and then asked the question, what are people doing differently, when we know that
hmm
weight is of enormous consequence. And there is a HEDIS measure or whatever that says report the weight annually for these populations so that you can write a program that will show those differences and you can see the variation that's there. I
hmm
haven't met anybody who's done that, but when you consider that in the Medicare Advantage population, for example, the percentage that have diabetes is not small. It's not like
No, no,
10%. It's not like 5%.
it's
It's sort of
so
like
large. Yeah.
35, maybe even 40% in some populations. It's a big grouping.
hmm Yeah, that is really interesting. Um, so with that, in terms of being able to understand from the patient standpoint, I think with fire fast healthcare interoperability resources, different methods of having interoperability aspects to it, wearable monitoring. Most people have smart watches, or many people do. They have their smartphone. Many people have smartphones to be able to help monitor them. Do you think that we're finally approaching the time, or the point in time where we're having personal health records that are going to be able to display these true longitudinal records for patients, and then that they carry that? It's not just something that they have, but it's becoming a point that's going to be essential for healthcare organizations to be able to have that information to be able to make decisions, better decisions. I think that's probably a more
I
accurate way of
hope
putting it.
so. I hope so, but I will tell you what challenges I faced trying to achieve that when I was
Okay.
managing the reimbursement model, because you have to start with all the codes and everything that Medicare produces, and Medicare pays for. Now let's talk about continuous glucose monitoring, for
Okay.
example, because that's a device that people wear that creates a huge amount of information about how their glucose excursions are doing, and the patient has also information as to what they did. Did they eat a candy bar? Did they have cornbread? What was it that was associated with it? Were they playing tennis? What were they doing? And so the amount of data is truly overwhelming. The payment model that Medicare has put on this is very stifling, because the people who own the devices hire a separate clinician to respond to the data from the devices rather than incorporate, and so they're billing for the monthly monitoring.
Hmm.
not the clinicians. And so what happens is it's almost like enforced um, balkanization or lack of integration by the payment model. And so the challenge is distilling that down. So we met with the physicians and said, what type of information from this huge amount of daily diaries and so forth, how would you like us to package that so that you could incorporate that information into your care? And it was very, very difficult, because the first thing we needed to do was overwhelm them with a massive data that wasn't useful and then pare it down. And um, we just never got far enough to know how to do it right. But I think it's a really important question, and I hope that there's a lot of people like yourself working on that, because we will be generating all of this. I mean, the Apple Watches and everything will be generating so much information about real-time blood pressure, heart rate monitoring, blood sugar monitoring, you name it. Um,
Hmm.
it's got to be distilled and incorporated into the care rather than being managed separately, um, and so forth.
Yeah, I think where my thought of this and my vision is more of being able to take this data and be able to refine it. So if you have a health information exchange and you have numerous hospitals that are connected to the health information exchange, right now we've got to the point where we've been able to build longitudinal records from many different types of EHRs. We've been able to now build different types of prediction models off of that using AI. And again, this would be human in the loop on everything. So the prediction models would say this person has a high probability of something like type 2 diabetes or maybe Parkinson's disease or those types of things. And it would just warrant, or even Kawasaki disease is something that we're looking at with children, to be able to warrant them, is this enough to be able to go in and get labs done, all right, based on the different types of pictures that they might have of different types of rashes and things that might be symptoms that could depict those things. So from that standpoint, I think it's being able to look at a strategic aspect of, here are the notable problems for this patient in addition to their 5 comorbidities that they already have. These are the things. And so we're going to be taking those metrics based off of those time spans and basically look at different types of high, lows, and what's the average on them, and then present that to the clinician. So that's what we're doing right now. We're also instituting blockchain, which I won't get into, but to be able to make this so that it's immutable and that you can have this direct connection. And again, this is kind of following the patient-centered medical home, where it's revolving around the patient. I think what I'm looking to do is to have the patient be in charge, whether that's the patient's caregiver, if that's the result for it. But essentially, if you have one hospital that wants to grab the records from another hospital that this patient is at, the patient should be able to go ahead and do that, as long as there's, again, that's why I was reading Insanely Simple from the Apple book, is to be able to have somebody understand, like, how can we make this extremely easy for the individual, so they're not saying, oh, I need to give this hospital read, write, and execute permissions, or I need this one to only get read permissions. So these types of things are, would you like your hospital to be able to have your sensor data that you're taking, also different types of hospitals that you've been seen at. And of course, this is all going into the longitudinal records that we have on the blockchain that's in distributed databases. And so everything is encrypted and basically has record locator services, so it can go ahead and find those different things that a clinician's looking for, that a patient's looking for as it goes in. But I think your point is very valid, that you can't give them an appending to what their longitudinal record already is, which is quite extensive for many patients, to just say, now start looking through all of this data and try to make any sense of it. It's not feasible. And
Well,
those
one
are
thing
some of the things that we're doing. Yeah.
I, I just want to connect to what you're doing, because I think that's amazing work.
Yeah.
For the primary care practices, they now have a process of gathering information before each visit, but especially before each annual exam. And
Mm-hmm.
that data gathering process includes which immunizations they're missing and should have recommended, which cancer screening tests they have sort of on tap for, and which other blood tests should be ordered routinely, sort of like cholesterol or something. So they have a process for pulling information together and incorporating it so that those services can be delivered at that particular time point. So let's say that we're talking about Kawasaki, and we're talking about, you've identified a cohort of people for which that is a legitimate concern that the physician should be aware of and should consider ordering a set of tests to make the diagnosis. And you want that to happen. Then, to me, what you need to do is look at what is their standard information incorporation process, and then work with them to see whether or not it's working for them. So that, because your AI is going to be what we used to rely on was a health appraisal that was a form that the patient filled out, and it was really crude, health risk appraisal. And what you're doing is you're heightening that so that you now are identifying certain peak risks that should be incorporated into the annual exam for evaluation, diagnosis, or treatment, whatever. And you've got valuable information that you can incorporate into their standard processes for receiving information. And then you need to just keep looping back with them to see whether or not you've overwhelmed them, or they're asking for more because they've had some real good outcomes that they never would have had but for acting on the information that you provided them. So one of the things that under HIPAA, you can share information with those who have an existing active patient-doctor, relationship. And for those people, the barriers to getting information should be minimized, because the biggest problem that we face is that they have a legitimate, as in having that existing care relationship, they have a legitimate role, and now they just need to have full information support to give the best care. So that would be my comment on it, as to how to take it to the integrating into care step.
Yeah. And then obviously with the feedback from the physicians, not just in terms of the amount of data, but the patient's outcome. I mean, that could be through a reinforcement learning model that would then be able to optimize what that would be. And that's kind of what you've mentioned before. Maybe, I hope I'm characterizing this right, but lift all boats in terms of taking those different types of outcomes and passing those, in the model itself. You're not passing any data, but the results of those, to be able to come to different types of standards or different types of policies that you would enforce. And so, yeah.
Yeah, and you would then be able to see whether or not the behavior that has occurred is consistent with the recommendations for care, or it's consistent, and the degree to which it is, and whether or not that's changed. You have that ability, but you do need to be able to communicate with them at a point where they're receptive to the information and it's actionable, and that will depend on their process as well.
Yeah.
For information gathering and action.
Yeah, that's a good point. So with mental health and physical health, in your experience, have they been treated as separate systems for too long? And it seems like a lot of the data says that we should aggregate those and be able to look at, from even just maybe common things of, adverse drug events and those types of things, based on someone's, physiological states compared to their psychological states. Is there big advantages of being able to have interoperability, get that far? I think, I don't know if you would agree, but I would say, during the ARA money and all the money for EHRs, most of that went to physical health. Very little of that went to mental health. Do you see that as a big challenge for physicians to accurately assess health when people are getting different types of work or different types of assistance from both the physiological and also with the psychological?
I consider them all the same except for the laws that apply. So
Okay.
in some states, and I think Michigan is one, there are some restrictions about sharing mental health information that are different from the restrictions for sharing other confidential information. And my view is that all of it needs to be treated very, very responsibly. So whether or not the person has HIV, whether or not the person has breast cancer, whether or not the person has depression or what have you, all of those need to be treated according to a single standard that respects things. And you
Mm-hmm.
can't be sharing information except with the people who are entitled. But if you have a person who just got discharged from a hospitalization for depression, and one of the causes for aggravating depression is um, drugs that can actually induce depression or make it more severe. You
Right.
begin to realize that treating it differently and separating that information off can cause harm for a patient. And I don't personally think that, I mean, in the old days, they talked about the stigma of the mental health diagnosis. Well, there's a stigma with cancer, there's a stigma with sexually transmitted diseases, all sorts of things have that problem, and we have to treat them all respectfully. But I don't personally think there's a good reason to set a different standard for information sharing between those two topic areas.
Okay. So if we're looking at the new generation of clinicians, even biomedical data scientists, health informaticists, everybody who's involved in this process, essentially a lot of them are going to be growing up with AI as a native tool, right? And so in terms of that, what would you most want to have them understand about what data can and what data cannot tell you about the patient? I think that's a really important thing that gets missed a lot in the classroom.
That, of course, it's something of an empiric thing. I believe that the first role of AI may be to deburden clinicians from things that are routine and don't allow them enough time to sort of focus on evaluating their sources of information and so forth. So what I mean by that is that a lot of what we used to do was document. That took a lot of
Mm-hmm.
time. And it's my understanding that a lot of the documentation is being done from basically AI assisted devices that have been active during the visit. And then it makes the work of the clinician easier. But the clinician has to read those notes, because even
Mm-hmm.
when you had people typing them, there were misinterpretations of what you said. The drug names got all wrong, or the doses could get wrong. And so you still have to have a process for reviewing. And AI can probably do that, make that easier by highlighting areas that don't quite make sense to AI. And then you have to do the same thing with other things that AI suggests certain diagnoses may be present that haven't been recorded before. And you have to insert into the process evaluating whether or not that's the case. And hopefully that won't be completely after the patient has left the office, because you have to really ask, when is that actionable? So let's say that after the visit with the child, you're now considering Kawasaki's or something
Mm-hmm.
like that. Um, it's kind of difficult when you're trying to sign your documentation to realize, oh, that's a brilliant thought. I wish I had it when the
Mm-hmm.
patient was there. So you always have to be mindful of the existing process and to incorporate into it, I guess, is the theme.
Yeah. Is there anything that, I think Abridge is one of the prominent companies that's doing a lot of the recording and transferring that. They're primarily associated with Epic, EHR. But is there anything from the physician's standpoint that routinely would be instrumental beyond just the data. So different types of facial expressions, different types of ways that they're responding, maybe body posture to different types of news that would be indicative to the type of, for example, even the care that they would want or that they would prefer. That something that couldn't be seen just in the data, even if it was recording the different episodes, the encounters that you had with the patient. Is that something that where AI could definitely miss that, even if it was tracking the conversations correctly?
Yes, and I think that that can be important, although I can't say that in my documentation that I recall providing a lot of information on the patient's body language or whatever, and how that influenced me. But there are patients who are clearly resistant to the suggestions for care, and that has to
Mm-hmm.
be documented. And I'm not sure how AI does that. So that is a good avenue to examine whether or not there's ways that AI needs to be improved to manage that sort of thing. Because I just had a call with my daughter who was a nurse at a hospital, and she was calling me driving home because basically the son really wanted the his mother in the ICU, in the intensive care
Mm-hmm.
unit. um, and virtually everything that he said was leading into, this is the reason why I think the person should be in the ICU. And of course, as the nurse on the case, it was not her role to decide what kind of bed the person was in and this kind of
Right.
thing. So you what you realize is that a whole lot of the conversation wasn't complaining about specific things as much as it was using these issues to advocate for ICU placement, because she had ICU before, and he recognized that there's a lot more resources being brought to bear on the patient. So those types of interpretations are things that clinicians develop skills at, and I don't know if how much AI is going to need to develop further before those issues fall under its domain rather than the human caregiver.
Yeah. And some of it might be even, I mean, the AI too obviously can be improved to some extent, naturally, but maybe also with the physician to be able to even repeat stuff that would be more types of subtle things that's known that would make a decision like that, but it's hard for the AI to pick up if it's just doing audio, for example. Yeah.
Well, since AI is
So,
probably going to be the tool that gleans critical information from all the longitudinal information in the past, because reading a record is not something that people
oh,
have a huge
it's
amount of time on.
right.
It's going to be useful in that respect as well.
Hmm. Yeah, and I think going back and making sure, I think that's the one aspect about some of the different types of more sophisticated models, whether it's deep learning or large language aspects of it. It's the interpretability can be hard. So I think that's where people in my field really need to spend a lot of time, because these decisions that physicians are making, they can be, some of them can be benign, but many of them are not. They're very significant for the outcome of the patient's health, and to really make sure that that explanation can not only be visualized, but it can be extremely clear. And it's a challenge to do, but it's definitely something that's important. Last question: what gives you the most optimism about the future of healthcare right now?
Well, I think it just keeps getting better and better, except for the financial people who have to sort of keep up with it. But the medical care keeps on improving, and our ability to track, intervene. I think that for me, one of the most exciting things is the use of treatments to impact obesity, because that was sort of the challenge of the age. And now we have to decide what is the best way for us to approach something that we've never been too successful with before. So there's always going to be these new things that create new challenges. But for me, the immediate thing is the excitement over taking these new interventions and really causing them to make a difference in the health of the population and making lives better. And there's just every day there's more things that allow us to do that.
This has been a tremendous amount of information, and I'm sure that the people who are going to be watching this are going to get a lot out of it. So, again, thank you, Tom.
And thank you, Guy. You're doing great work up there, and I'm always very grateful for you informing me of the latest advances, because that is one area that I don't get very often, and it's very useful, and I always appreciate hearing from you. So thanks again.